Dear colleagues, my friends, welcome everyone. In the next 10 minutes I would like to present my 12 months progress in the Translational Medicine program. My name is Boldizsár, yes of course. So my vision is that the best medical knowledge and practice needs a constant update by scientific research, and my mission is to develop and refine intensive care strategies for resuscitated patients. In the last 12 months, we set some specific and in the literature unclear goals according to the post-cardiac arrest and resuscitated patients. The first one is an investigation of prediction scores in out-of-hospital cardiac arrest, and the second and the wannabe third one is a comparison prophylactic and clinically driven antibiotics after successful resuscitation. So, first, I would like to present my results from the first project. Shortly about the background, it's already known that the incidence of out-of-hospital cardiac arrest is between 70 to 170 per 100,000 inhabitants in Europe per year. And despite advantages and the continuous development in resuscitation and post-cardiac arrest, the survival rates at hospital discharge remain low, range 8%. This study could clarify the question that which score is the best for estimating neurological outcome and the mortality after successful resuscitation. And this is relevant in the clinical practice because using these scores in the ICU and in a hospital, we can prevent the healthcare and the ICU system to apply costly and intensive resources in cases of futility. We made a systematic search in 4 databases last year with the search key you can see below. And our clinical question is to follow which is the most accurate and reliable prediction scores in out-of-hospital cardiac arrest patients in cases after successful resuscitation. Below the question, there are the PICO framework. I would like to highlight the first outcome is the neurological outcome, and the secondary was the mortality. On the right side of the slide, you can see the Prisma flow chart of the selection process. And after the selection overall, we were able to include 35 papers to the systematic review and 12 to the meta-analysis. In the slide, you can see our geographical representation of the risk of bias and applicability according to the probas. Just to mention the low risk of bias and the low concern regarding applicability is marked by green. As a part of the systematic review, we collected the most frequent variables used by different neurological outcome prediction scores, and tables on the right side you can see the most common variables was the initial rhythm, the age, the pH, the no flow time, the low flow time, and the witnessed or unwitnessed arrest in these scoring systems, what we identified in the systematic review. Now I would like to present the main results of the project. First of all, we checked all the outcomes and all the scores, and if there were at least 3 related articles, we collected the AUCs and their confidence intervals, and we performed the meta-analysis using a random effect model to gain pooled AUC. So according to this methodology, we found 3 scores which has at least 3 results and cohorts, and we were able to make pooled AUC. So in case of C-graph score, we were able to make a pooled AUC which was 0.80. In case of OHCA score, it was 0.84, and the highest was in the CAP score. In case of CAP score, it was 0.89. We found two scores to predict in-hospital mortality, and in both cases, both scores, the pooled AUC was 0.84. So, in the case of neurological outcome at hospital discharge, because there were three prediction score, we could make a ranking list based on the statistical, the practical, and overall performance. And overall, the CUP is the best prediction score to predict the neurological outcome at hospital discharge. As a part of the analysis, we were able to make an additional one with the Stenhauser method. In this case, we could make a summarized ROC curves from the individual ROC curves, and on the right side you can see these curves and their confidence interval. And the AUCs as well. The AUC is higher than in the CUP than the OHCA, but this difference between the two scores is statistically not significant. To summarize, there are some strengths and limitations. First, about the strengths. We identified all the prognostic scores in the literature which were suitable to estimate the expected perspective of successfully resuscitated patients, and we were able to set a unique hierarchical order between the score system and the neurological outcome at hospital discharge. But there are some limitations as well. First, that not all identified prediction score systems were capable to include the meta-analysis part, and a lot of analyzed articles based on retrospective core, and the risk scores may not give the same prediction. This is a very important part. It's not give the same prediction accuracy in different populations. To conclude, we can say that CUP is the most accurate score system to predict neurological outcome, not for the accuracy, but the rapid availability of the necessary data at admission. And based on this, we recommend the use of the CUP score system in the everyday clinical practice. The NUFLIS and the OHCA score are quite accurate to predict in-hospital mortality as well. In the clinical practice, the high-risk category of patients with this with very poor prognosis can be identified with this best scoring system, and we can prevent the healthcare system, as I said before, to apply costly and intensive resources in cases of futility. The field of research, we need more studies to investigate deeper and analyze deeper in the field of this scoring system, because as you see, there are a lack of data in a lot of publication. So you can see the status of the first manuscript. We finished the draft with the supervisor, and we are, after the progress report, we are planning to send it to internal review, and after successful internal review and language editing, we are going to send it to the critical care, which is a Q1 journal from New England. And in the next 1 minute, I would like to summarize the second project, which is a meta as well. The early onset pneumonia is a frequent infectious complication due to aspiration during the resuscitation and the airway management and the immunological impairment. And there are not known and well-defined data whether the early timing antibiotics can reduce the risk of pneumonia or other infectious complication. So our aim is to compare the effect of the prophylactic and clinically driven antibiotics. The clinical question is the same. Does prophylactic antibiotics decrease the rate of mortality and the incidence of pneumonia compared to clinically driven antibiotics? You can see our PICO framework, and our hypothesis is that the prophylactic antibiotics is superior to clinically driven antibiotics. We made the systematic search in 5 databases in the last year, the search key, and overall we found 14 articles what can be included in the meta-analysis. And now we are one step before finishing the data extraction, and you can see our deadlines too in this progress slide. And because of the lack of high evidence in the second topic, we are planning to make an RCT in the same topic as well, and you can see my overview of the topics, and thank you for your attention.
I think this is a very interesting topic, just for me as well. But in this case, there is no question. I would like to ask, how do you think how you or we could validate these core systems in the real life? What do you think? Where can we apply these systems? For instance, the CAP.
I think, first of all, we can validate in a prospective register. I'm not sure that we can make an RCT or some higher evidence in case of this course, but prospective register and the high number of registers is really good. But I have to underline again that this course may not give the same result in different ethnicities or different continents. So we have to go around this topic and check, then double check the.
Yes, I think from the clinical point of view, it is very important to have very easily and very rapidly accessible data from the patient when the patient is admitted to the ICU, driven by the ambulance car. So very rapidly acquirable BGA, blood gas analysis result, and the lab test and an ECG and an echo would be the most sufficient one. And CAP score has some parameters that we could use immediately at admission, because during the post-cardiac arrest care, we do have to wait at least 72 hours just before predicting any outcome of the patient, neuro, mortality, any else. So it's not easy for us, and we have to spend a lot of money on these patients. Of course, we do not leave anybody dead in the ICU. So we do our best. Rita?
I would have another question. So how would you implement your findings? Because based on your findings, the CAP score has the best performance. So would you modify your daily clinical practice, or I don't know if you are using currently this CAP score in your practice?
We are not using it, but...
will you, for example, based on these results?
I think yes. I think the easiest way to use it is to implement to the electronic system in the hospital. So we have a bed map system, and it can calculate automatically from the first data, the first parameters at admission. So I think the usability of this course is easy, but we have to validate and we have to make sure ourselves that it not give for us false prediction before we start to make conclusions from it for the colleagues and for the relatives as well.